with my hair.
Um, Perfect. And let's see, feel free to pick
Yes,
on anybody, especially Christy and Spencer.
fair
What
enough.
a
Okay.
bully-free program.
I mean, he's already suffered through part of a day with me.
It was awful.
Okay, so we're talking about scaphoids today and mainly fractures, not a ton of AVN. Okay, so overview for wrist fractures that you see in clinic, it's about 15% of all wrist fractures. But when you're looking at carpal bones, it's about 60% of all carpal fractures. Male preponderance, and it's most common in the third decade of life. As far as location goes, majority, 65% are of the waist, 25% are of the proximal pole, and then about 10% are of the distal pole. So typical mechanism of injury would be hyperdorsiflexion of the wrist in the pronated position and ulnarly deviated like this. Okay, it's usually seen in contact sports. This is a picture of Kendall Marshall. He had a scaphoid fracture while playing, I think, at North Carolina, and then played in the NBA until 2017. But there was a great video that not going, sorry, that showed how he broke his scaphoid on camera. So there are a lot of different ways to think about the scaphoid. I kind of like the twisted peanut analogy. So if you take, like a peanut in a shell where it's kind of like the hourglass shape, and then you kind of twist it and stretch it a little bit, that's what a scaphoid looks like in my peanut-sized brain. It's about 75% articular surface, and it articulates with quite a few bones. So when something goes wrong with that, it can mess up a lot of stuff. That stuff is the lunate, trapezium, radius, trapezoid, and capitate. And if you think about it, that's the progression of arthritis too, right? So the vasculature, which is what we hear about a ton, we all know that the vasculature, majority of it, 80% of it, comes off the dorsal ridge, which is a branch off the radial artery. So that's the dorsal blood supply. You also get some volar blood supply from the radial artery that's off the superficial palmar branch, and that'll come in through the distal tubercle on the volar side. I thought this was a really interesting paper looking at scaphoid blood supply. Again, it talks about most of the blood supply coming through the dorsal ridge, but this paper, which Steve Moran was the main author, was pretty neat because they kind of looked at the different shapes of scaphoids and tried to correlate the shape of the scaphoid with the type of vasculature, and did that maybe mean anything as far as like perfusion, fractures, things such as that. So they looked at a bunch of scaphoids and they classified them in two different types. So type 1 is like the full scaphoid, which had a more developed and interconnected intraosseous blood supply, right? That's important because most of the blood supply from the scaphoid, it's going to come intraosseous, right? Because it's covered in articular surface. Type 2 is the slender scaphoid. So it's got a less developed intraosseous blood supply. It's just not as robust. So this was differences between A and C, which is type 1, and then B and D, which is type 2. And so you can look, there's definitely a difference in the blood supply and the amount of branches, the permeation of the bone, all of that. And so what they thought maybe and discussed in the discussion section of this paper was, well, maybe a less robust blood supply could increase the risk of like nonunions, AVN, a lot of the things that we see go wrong with a scaphoid. And logically it makes sense. Now this paper didn't prove that at all. It postulated it, but it makes sense. And this is a paper that I've kind of thought about over in my mind again as I fix these, kind of guiding my dissection. And especially if you're going dorsal, you kind of open up the capsule, you start to see the dorsal part of the scaphoid, and you think, well, gosh, I'm trying to get this to heal and I'm bone grafting it. Am I cutting through the blood supply? This is a neat paper to look at. So what do we find on physical exam? Swelling is variable. Sometimes you'll see it, sometimes you won't. It depends on how long they have had it. Sometimes that's why you do it arthroscopically. I see why you're that is true. There's room for that at the end. We'll talk. They'll have variable pains. Sometimes people have pain in the snuff box. Sometimes people have pain just along the scaphoid tubercle. Sometimes you can elicit pain by just loading the scaphoid through loading the metacarpal, almost like you would a grind for thumb arthritis. And sometimes people will come in and say, yeah, my wrist hurts. It just kind of makes this clicking noise every time. So the physical exam can be quite variable, especially depending on the duration of the injury. So imaging, there are a lot of different things that we can do to look at the bone. And the question is really, what are you after? Basic films that you're going to get on everybody would be an AP, a lateral oblique, and then a scaphoid view if you think that's what you're after. So that's going to be, the wrist is going to be about 30 degrees extension and then 20 degrees of ulnar deviation. So the film is going to be shot like that. So you see the nice long waist of the scaphoid. If you have somebody that comes in that has pain, just immobilize them, assume it is broken, and you can repeat films in 2 weeks. You can do other things than that. You can get a bone scan that'll show an occult fracture in an acute setting. It's pretty sensitive and specific, but I can tell you I've honestly never ordered a bone scan for a scaphoid fracture. You can also get an MRI. It is the most sensitive for an occult scaphoid fracture at greater than 24 hours. Fracture and ligamentous injuries will also usually be shown there, so that's pretty useful. Say you don't see a scaphoid fracture, they could either have an occult scaphoid fracture, or they could have, say, like an SL injury or an LT injury, something like that. The MRI would tell you both of those. It may give you the idea of the vascular status. And then when you're looking for AVN, you're going to pay particular attention to the T1 images. MRI is quite sensitive and specific. And the main issue that I have with MRIs is getting the patient to get one, especially if they have some of like the more government insurances. They'll want a pre-cert, they'll want a peer-to-peer. It's just not always very time friendly when you're trying to usher a patient through this process. You can also get a CT scan. That'll give us more of bony definition, right? So you'll see the fracture location, the alignment. Is there displacement? Is there bone loss? Are there fragments? And it's really great for also if you're looking for progression of healing versus a delayed union versus a non-union. These are easier from just a logistical standpoint because they're cheap, fast, and they don't usually need a pre-cert. If you're going to get a CT scan, make sure you specify that you get 1 millimeter cuts through the axis of the scaphoid. Otherwise, it's just not going to be nearly as much of a service to you or the patient as you would prefer. It's about 62% sensitive, 87% specific. So conservative care for this, things that would be conservative care appropriate would be a stable fracture pattern, non-displaced, or less than 1 millimeter displaced. So if you see somebody with an acute, stable, non-displaced scaphoid fracture, the odds that they're going to heal this are about 90%. This is red because it's not really like clinical practice guidelines. This is just what I do. Every fracture I see in clinic, I ask them if they have a history of vitamin D deficiency. If they don't, I usually have people take about 2,000 international units a day until they heal. If they do have a vitamin D deficiency, then usually by definition, they're not treating it. That has been my experience. And so I'll check a vitamin D level, and that'll tell you, if they're super low in the teens, you're going to need to do the 50,000 once or twice a week. I really try to get their vitamin D around 35 to 40 to heal. And again, that is personal opinion and experience, not as much fact.
Dr. Dempsey, sorry to interrupt. Is that 1 millimeter on plain films or is that always on a CT?
Oh, you're gonna have to get a CT scan for that.
Okay.
I don't think I would trust 1 millimeter on a plain film.
Perfect. Just checking. Thank you.
So as far as conservative care goes, please immobilize these folks immediately. When they are not immobilized immediately, in a thumb spica cast or an exos, something like that, if they're out of immobilization or not immobilized for greater than 4 weeks from the injury, they've got a calculable increase to their non-union risk. And that's unfortunately how I see most of my patients. How do we immobilize these? You can do a thumb spica, or if you really don't like them, you can do a long arm thumb spica. That's really what we call the punitive long arm in my clinic. I'm kidding, we don't do this to anybody. I use an exos, or if it's a pediatric, I'll cast them. Athletes, something about athletes, if you're going to have them return to play, you have to make absolutely sure that they're healed. And the best and the only way I trust that is a CT scan, because especially with the collegiate athletes or the weekend warriors, the minute you clear them to go, they are going to go wild. And so you need to be able to trust that the bone is healed. A lot of times, if I've got a delayed union or a non-union that I'm trying to treat, I will use a bone stimulator. That's a pulsed electromagnetic field. There is some literature that suggests that it would benefit in a delayed union, but that's not gospel. Everybody does not use that. Okay, so how do we fix these? We're just going to start simplistically on the fixation ladder and then escalate. So percutaneous fixation, that's usually what we do for an acute unstable fracture pattern. Proximal pole, less than 1 millimeter displacement. You can do this for a non-displaced waist fracture, and it has been proven that the patient will have faster return to work or sport and a decreased union time, and it's a similar cost to casting. Percutaneous fixation will get you to union about 90 to 95% of the time. Again, I usually get a CT scan for athletes or folks that I'm more aggressive with ensuring they've healed at around the 8-week mark. There are multiple ways to fix it. You can go dorsal or you can go volar. Dorsal, you usually use for a proximal pole fracture or a waist. When you're doing a percutaneous fixation, you do need to be aware of EPL. It always seems to be exactly where you don't want it to be. So, i.e. wherever your pin is. The benefit of that is that you do preserve the dorsal ridge. You get your starting point percutaneously, and you can make just a tiny little nick and spread down. Make sure you get EPL out of the way, get down through the capsule so you can at least visualize the cartilage and make sure that the bone, screw truly is subchondral when you think it is. Scaphoids will trick you that way. So the next approach would be a volar. Frankly, I do a volar less for percutaneous. So that's going to be right next to the FCR. You do have to be aware of the radial artery. You usually use that for a waist or a distal pole fracture. Usually when I think about, a volar approach to the scaphoid, it's going to be more often where you're in a situation of bone loss and you're trying to correct a deformity, such as a humpback deformity. The benefit there is it avoids the dorsal ridge, which is the majority of the blood supply. Okay, when do you open these up and fix them? Displaced fractures, comminuted, unstable, bone loss, which frequently goes with chronicity. If they have a DC deformity, so that means it's a more long-standing fracture, likely with some shortening of the scaphoid. If you have a vertical or an oblique fracture, i.e. a fracture that's difficult to make sure you have it actually fixed in the correct plane. And one of the things that's important is the union rate does correlate to the accuracy of reduction, especially if it's a widely displaced fracture. I want to go back. This was an interesting paper, the one I've got at the bottom. What this talked about was when you're fixing a scaphoid, you don't always need to do that perfect angle that you see in the textbook. Sometimes you put the screw in a place that's a little bit different to fix the fracture pattern that you're dealing with. So if you start at the tip of the proximal pole, sometimes that doesn't allow you to actually compress across the fracture site. So that's something that you want to think about when you're putting your scaphoid screw in. I think Spencer and I talked about that last time we were fixing a proximal pole scaphoid, because we had a couple of different images as to where we could put the screw, and we put one in pretty close to perfect, and then realized, you know what, I just don't think that's really holding the fracture as much as we want, so we put a second screw in. Okay, on to non-unions. 5 to 10% of all comers will get that after conservative care, and 25% following surgery. That always kind of seemed like a double-edged sword, but it's probably that you were operating on more people that were less likely to heal anyways, right? That would mean you were doing the appropriate operative indications. So what are the risk factors for a non-union? Greater than 1 millimeter displacement, proximal pole, a vertical fracture pattern, and that goes back to how do you put the screw in to fix the fracture. Age, nicotine use, and vitamin D deficiency. So,
Forgot one. I said, forgot one thing, delay in diagnosis.
Oh yeah, we talked about that earlier, but yes, that's true. So, when you're looking at these risk factors, I kind of think about these risk factors every time I see a scaphoid fracture, not just a non-union, right? So you look at these risk factors and you modify what you can, right? So you can modify nicotine, maybe. You can modify vitamin D, and you can modify how you fix the fracture pattern that you're dealing with. Okay, non-unions. How do we begin to work these out? Well, you start with labs. Infection's unlikely, but possible. The first lab I usually go to is a vitamin D level. Then I usually kind of start to look pretty hard at the timing of when does the patient say they got injured versus how is the bone behaving. If you're going to get a CT scan, that's when you're starting to look for bone loss. Is it linked stable? Is it linked unstable? And then you can get an MRI to assess vascularity, but that's still not great. You're going to have to order that with contrast, of course. And I think there's a shortage of that anyways right now. Okay, so, the overall thing, and I think Spencer and Christy, this is important for you guys, is when you're dealing with non-unions, the first thing you need to do is ask yourself, why do I have a non-union? How did I get here? The two most common reasons that bone does not heal, would be either lack of stability or a lack of biological ability. Okay, there are other things like infection, like thyroid disease, much less common things, but mainly it's stability or biology. Okay, so the way we pick to fix a non-union has to do with why do you, what is the problem? Fix the problem. If they don't have stability, they need a screw. If they don't have good blood supply to the proximal pole, i.e. it's a biological issue, then you need to give a blood supply. So simply starting with a scaphoid fracture with bone loss, you can do an open reduction with bone grafting. In the US, the FDA defines a non-union as a fracture that's not healed at 6 months. So anything before then would be a delayed union. But indications for an ORIF with bone grafting would be a lack of union by 6 months. I would argue it's earlier than that. No snack wrist, no osteonecrosis. And you can also think about doing, depending on how much bone you've lost, that you would determine with a CT scan. Is this something where you can just pack in some graft from the distal radius, or is this something where you've really lost some height and you're going to need more of a corticocancellous bone graft? If you need that, you're usually going to have to go volar, right? You can use a cortical strut to restore the length, alignment, and angulation, and that has a pretty good union rate, 92% for a non-union. That's good. Okay, the next kind of hierarchy would be blood supply. Say you don't have much blood loss, you don't have much bone loss, but you need blood supply, or you have some bone loss, not a humpback, but some. And you need blood supply. So there are a ton of different vascularized grafts you can do for that. So dorsally, you can do the Zeidenberg or the 1,2 ICSRA. You can do a corticocancellous, or you can just kind of take a fascial sling and move it over. I mean, I don't know why you wouldn't take bone if you could, but this is a good surgery. It's technically demanding, and to me, the anatomy is quite variable. Some folks, just kind of look the next time you're on the dorsum of the wrist, when you're doing a de Quervain's release, when you're doing, like an extensor tendon repair, just take a look. Try to look at that dorsal 1-2 space, and you'll see there's a ton of variation. Some people have nice thick arteries that you'll see coming off distally and coming back proximally. Those are the ones that are going to do great with a 1-2. But like the one Spencer and I did a couple weeks ago, no, last week, we opened it up and it was just, I wouldn't trust it to heal anything. It was just very paltry, and it looked almost like the blood supply was coming from proximal, not distal. It just didn't look good. So that's kind of one of those grafts where it may or may not be there. You better have another plan. Methulin, which we're probably going to do, 2 weeks from now for a different scaphoid fracture, that is based volarly. So the way I remember it is all those little arteries that I just like burn when I'm doing a distal radius. That's what we use here. It is off the volar carpal artery. You can get like a corticocancellous piece of bone with a strip of fascia attached. And again, we use this more for a humpback deformity because you're already volar and you're correcting that flexion. I thought this was a really great picture. This was off of, so the right-sided illustrated pictures off the Satirianos paper on his graft. And then the left table is part of a review of different vascularized grafts you can do. But like kind of the point of this is look at the vasculature of the distal radius. There's a ton of overlap. There's a ton of redundancy. And my take home from the end of the day is if I'm trying to get a vascularized graft and the typical one doesn't look quite right, or it's not as robust as I want, just look around, look for another vessel that looks pretty big and looks like it's going down into the fascia and the bone. There are a lot of different options here. So this was a really great review of the anatomy of the 1-2. I love this picture because it's a nice stout. You can see the radial artery, and then you can see the little branch coming up and around. So the black arrows, like that's what you're going to rotate, that vasculature. That's going to pop down into the scaphoid. That's nice and robust, and you can see it coming off of the radial artery, which I think is great. So as a rule of thumb, it's usually about 1.9 millimeters proximal to the tip of the radial styloid coming off the radial artery. You always take it with the surrounding tissue, kind of just like the other grafts. You imagine it's kind of a funnel. You want a large swath proximally, and then it can taper off distally. Theoretically, it can reach dorsal or volar, but I don't think, I just don't know how I could get that to work and trust it to go volar. So union rates there are all over the place, depending on what paper that you look at. There's a paper from Morris et al. That showed basically 100% union rate. I'm not going to get that. I don't think anybody that does enough scaphoids is going to get 100%. Or I'm not. There's a paper by Cheng et al. That's a lot more believable. They had 34 out of 50 achieving union, but I thought it was interesting because they kind of caveated in their paper that they didn't think that it should be used for and was not used for humpback, collapse, prisers, and an SL dissociation. This is my current favorite. I like this because it's easy. It relies on a lot more vasculature. There are more variables. There are more ways that you can get blood supply in this swap. It's technically pretty easy. And I've used it for lunate AVN. I've used it for scaphoid. I think you could pretty much put it about wherever you could rotate it to. This is another picture of how they raise the graft and the capsular swath, and how you can kind of swing it down into the scaphoid non-union and theoretically press fit it, and then just put a screw across it, which that's exactly what Spencer and I did for one last week. Apparently he's better at press fitting than I am. It worked great.
Just dumber, more robust thumbs. That's all.
So, their results, they reviewed 13 people. This was Satirianis's paper, continued. So they had 13 patients with symptomatic non-unions, 10 out of 13 healed, 8 out of 10 that had, let me rephrase that, 10 of the 13 healed to their non-union. Of those 10, 8 out of 10 had a presence of AVN. And then out of the 13, they had 3 persistent non-unions. So, and the follow-up's 19 months, which everybody should be healed by then. But you're probably not going to see the long-term consequences and fallout of the injury. Okay, so this is just another close-up pedicle, image of the pedicle, and then there's the bone you can plug in. We've already kind of talked about this. The next thing you can do is like a vascularized free graft. Full disclosure, I have not done one of these since I was a fellow. That's probably not part of my regular armamentarium. These all go to Nikki, Dr. Zelinsky. So you can do medial femoral condyle off the descending geniculate artery, or you could do like a vascularized graft from the iliac crest off the deep circumflex. Again, this is another vascularized graft where, like, in orthopedics, when you're plating the distal femur for like a fracture, you open it up, you get down to all these stupid little bleeders, and you just like burn them all. And that's what we used for medial femoral condyle. Okay, so we'll talk briefly about scaphoid non-unions with advanced collapse. You'll see that the arthritis will progress in a predictable fashion. So they'll get radioscaphoid. The arthritis will go over to the capitate, and then it'll, at that point, just be pancarpal after that. So how do we treat these? By stage. So stage 1, which would be, radioscaphoid, you can scope it, you can debride it, you can do a radiostyloidectomy, and you can do a denervation. Stage 2, 3, you're looking kind of more about doing something more aggressive. So you could do a PRC, you could do a scaphoid excision, a 4-corner fusion, or you could do a total wrist fusion. The basic premise behind it is figure out which joints are good, try to save those, figure out which joints are bad, and try to fuse those or remove them. And just remember, you want to articulate through the good joint. So that's pretty much the overview. And the next part of this is cases. So wake up, fellas.
Can we ask questions?
Yeah.
And this kind of to Dr. Dempsey also wants to answer. Is there ever been any literature looking at bone grafting scaphoids primarily? Like if you're going to open it, just because like the numbers quoted for non-union after you fix it being 25%, then it seems like you bone graft it and those numbers seem pretty high. And you kind of like the dorsal radius isn't that far when you open it, if you do open it. Sorry for all these specific things.
mean, the ones that I usually end up grafting that are for an acute fracture are the surprises that aren't quite as fresh as they were initially billed. If that answers your question. I mean, if it's an acute fracture, they really shouldn't have bone loss. People lose bone with scaphoid fractures when they don't heal.
I guess another way to ask the question, because a lot of them seem to heal with that, like scaphoid non-unions seem to heal when you bone graft them, but I guess that doesn't parse out why they didn't heal in the first place.
I mean, maybe.
Okay. Just depends. Why? But what's the purpose of grafting? Like, what is grafting achieve?
Bring in cells for mechanical.
Yeah. So Dempsey kind of said earlier, it's for like kind of bone loss, right? So you have a non-union, you're like missing some bone, you have some defect, you need to fill it. So an acute fracture, unless you have like really high energy, or unless it's Nikki who has a bullet that somebody shoots a big bullet wound through the scaphoid of Grady, like you're usually not going to have a big bone loss, and so that's the argument against grafting, is that you don't have that bone missing.
Yeah, I guess not necessarily like cancellous or not cortical necessarily, but just kind of interesting because like I would want to look at the papers of why the scaphoids didn't unite. Because in my head, I'm assuming that they just went on to not unite, but that's probably not a study of like nice non-displaced fractures or easily compressed fractures.
Well, I was going to say it came from one of your institutions. I think Ruby looked at like 200 plus cases of scaphoids in London, Ontario. I mean, the risk factors is exactly what Dempsey essentially told you, right? It's substantial displacement, delay in diagnosis, location, nicotine, all those various things. I mean, you can predict a fair number of the patients that aren't going to go into union based off of the issues that they have, and smoking, et cetera, et cetera. So I will tell you this: scaphoids are very humbling.
Yeah.
A very humbling part of what we do.
The more I do this, the more I feel like it's a crapshoot. I mean, you just never know. But the biggest thing that when I'm seeing a patient for the first time with a scaphoid fracture, the biggest thing that makes me go, how long have you had it? Duration, I think, if you were to stratify how bad risk factors are, I would say duration of injury is one of the worst.
Is there a time point from when you say you will no longer do it based off of how long someone's had it?
No, I mean, it depends, right? So like if they have a humpback deformity and they're in full on DC and it's been broken for a year, like that's not going to happen, buddy. Like those rarely heal. But say we think it's been there for 6 months, they really don't have any bone loss and they don't have any DC, and it's just kind of sitting there hanging out. I think those have a better chance of healing, but not great.
Yeah.
I've actually got a couple of those cases.
No, they're in there.
I may switch to all arthroscopic bone grafting if we get this one that we did on Friday to heal. That way we don't put down any of the blood supply.
See, it's cool.
I'll use my end of well, I guess technically I used to do it arthroscopically, but not the way we just did it. I used to just push the graft through, but different from this technique. But if this works with an N of 1, I'm going to completely switch.
It was cool. Dempsey, I sent you a email about this, but if you ever want to do it scope, we could do one scope together on Monday. It was cool. I did a gut check. I think I converted gut check. It's a cool way of doing it.
I will facetiously say I will switch, but truthfully, I mean, if this kid heals this, I very well would consider. I mean, look, it's kind of one of those things. I still think like I wish we had more of the actual like proper tools to be able to do it easier and less futzy, but it's not like it's that.
Less futzy. Gut check. It took us like an hour and a half.
Who do I have on here? Courtney's on here. I think it was like a 2.5 hour procedure.
It was not a 2.5 hour procedure. We started like I scrubbed in at 3 o'clock, which means we started our procedure at like 3:15. You didn't even get into the room until like after 4. So I don't want to hear this 2.5 hour procedure. And we were out before 5.
We were not out before 5.
Spencer, when did you leave to go to the airport?
Spencer went to the airport because he was going to miss his flight.
It was a shade. It was right around 5 I left. Like, and we're
trying to back out of this. It's just like, please don't involve me. Canada's neutral.
I will concede that I think that the technique is probably in the patient's benefit for the lack of stripping of blood supply, and it's certainly doable. And it does not mean that it's not technically challenging or time consuming. I'm not saying you can't do it. I just said I would actually do the next one that we have. I'm more than willing to do another one. I just think I mean, look, it's just like any other stuff. It's a technically challenging. Why don't we do some cases? Because I think the cases, the truth is no single scaphoid non-union is like another. And that's part of the problem as well, right? Is
Mhm.
you can try and classify these however you want. And that's the other thing is I remember as a fellow, there was an article, I think it was by Rosenwasser then that talked about like, if it's greater than 2 millimeters or what's displacement and looking at CT scans and all this stuff. But the truth is you can't even get people to agree on how displaced it is, and all those things. So it's interesting. I think cases are actually a great way to learn. But Wax, I do agree.
Yeah.
I think arthroscopic ideally is beneficial because of lack of open, right? You don't have to open up the dorsal ridge. You don't have to, you keep all the blood supply and all the components technically intact. So there's definitely benefit to it.
Agree.
So yeah, I mean, I think the reason for going through cases with scaphoids is I will freely say I do not have a magic bullet or a magic algorithm to treat every scaphoid fracture. Again, I kind of feel like it's a crapshoot. You can do what the literature says and you feel better about it. If somebody else says it's okay too, but these are not predictable and they're humbling, just like Dr. Gottschalk said.
So Dempsey, let me ask you this question, right? What do you do with these patients that they come to you and they're 16 or they're 20 and they 4 years ago they injured? Are you going to go straight to something? You're going to say, look, I'll try and fix you.
Um,
No arthritis, just a non-union.
I try to fix it.
Yeah.
They're
The reason I
16.
say that is because, right, 4 years ago, I mean, there's almost no chance that they heal, but oftentimes, right, I feel like you put a screw in, you get them to be non-painful, even though there's a non-union. And maybe you bought them who knows how many years without arthritis. I don't know.
Yeah, I mean,
The classic paper of progression to arthritis after scaphoid non-union was actually written by Maureen O'Shaughnessy, Wags's friend from Mayo.
didn't know that.
Yeah. I just was sawing to them.
So with that, let's get started. So this is Asar. He's a 52-year-old right-hand dominant male, presents for right wrist pain, very active, goes to the gym 6 days a week, lifts, cardio, like biceps bigger than my calves, and drives a MARTA bus for a living. He had a remote history of a car accident, no additional trauma, just kind of like my wrist hurts. So then we get these x-rays and there you go. Okay, so Spencer, what do you see?
So looking at this, again, views aren't perfect, but he's got some SL widening, or there's like a very proximal pulse scaphoid irregularity to me. Like I would get a CT to quantify this. I don't see in the lateral a bunch of dizzy or anything else like that. And this scaphoid appears to be like an okay position. But I don't like the SL area. Like I think it's a bony injury given the talk, obviously, but
yeah, I mean the truth of the matter is I don't know how this guy got here. He could have had AVN, like idiopathic AVN of the proximal pole, or he could have had a proximal pole fracture. I don't think he had an SL injury because the lunate looks pretty well centered. But it was either AVN of the scaphoid or fracture with subsequent AVN that was, just never diagnosed.
And it looks kind of cystic-ish, I guess, in the AP. I can convince myself, but like, I don't know, like it's not awful, but trying to convince myself at that mid-ridge.
It's not good. Like, look at his styloid. He's got like the teeniest little lip on his styloid.
Arthritis too, yeah.
Yeah, but the capitolunate looks okay-ish. Radiolunate looks okay-ish. So what would you do? Comes into your clinic and tells you he has wrist pain. And don't tell me a steroid shot.
He's painful?
Yes.
Can you go back? I would CT it first to look at it. Like I'm thinking, I don't know that I can fix that because there's not really anything to fix. And he's already got like early slack or snack, whatever we're calling this, arthritis. You could talk to him, this is going to be controversial, but like about a four corner or something else like that, like a partial wrist arthrodesis to maintain maybe some... I thought that was offensive sneezing. He hates the four corner.
I was about to say, I thought that was actually like some other weird thing of telling him that he really disagreed with what you just said as well, Spencer, but I guess that may have actually just been him sneezing.
A real sneeze, but
Uh,
yeah, it's like a four corner with a scaphoid.
He's gonna say, "Do not read his article." That's the first thing he would say.
Well,
Said that all the time.
this was done by Amanda circa what year is it? 2022. I think this was like Amanda circa 2018. So this is what it did.
Okay, at least we agree.
Yeah.
So let me ask you this: so what made you decide to go straight to? Well, so what was the diagnosis?
Broken scaphoid, and not broken like fractured, just not working.
I would say he had, like a variant of a scaphoid non-union in the sense that the proximal pole died.
Gotcha. And did you have an MRI or CT that really convinced you that that was the case, or did you scope it or anything like that, or no?
I did. I don't have the images because they were on some outside disk that nobody ever uploaded. But basically, he did have some early capitolunate arthritis. He definitely had the radius scaphoid joint was toast. And what pushed me in the direction of a four corner fusion rather than a PRC was that the best joint was the radiolunate joint, and the capitate was starting to show some early wear. So this is what he got, and he wanted a one and done. Honestly, this was before I really started doing a lot of denervations too.
Yeah, the denervation may not have gotten right. The problem with the denervations is that you don't kind of get the radial sided stuff unless you do something arthroscopic to get it. So it's not always a slam dunk. So did he heal this?
Yeah, I see him now for like a trigger finger.
Do you did you just use the scaphoid as bone graft, or did you use something else for bone graft, or?
I think I just used the scaphoid, and he had really good bone to begin with. Very early in my career, I would use the scaphoid because that's what everybody at Kleinert did. But then a lot of the scaphoids that I took out, I was, you just kind of look at the bone and you're like, this is trash. This is terrible quality bone. Why am I putting trash in here? So this guy actually had really good bone. So I just burred the cartilage off the capitate and the lunate, and then you just kind of do the little K-wire holes. Yeah, he didn't need much. So he went on to union.
Can I ask a question? For that one, like it seems like he was like an older person who already had like arthritis, but if he was a younger person that didn't have arthritis and came like that, would you try and do something like an MFT or to like reconstruct the proximal pole, or would this still be like your choice?
I mean, that's not, I think if it was in my skill set, I would talk about it, but frankly, it's not in my skill set. If you're comfortable doing it and you've done it, you're going to know the indications and what you can reasonably get and what you can't.
I guess you could also do like exotic things, like, and I didn't say this, I've not seen it, but like you
Go
could do,
back
like,
to the proximal, the X-rays. It was arthritis.
just the beaking of the radius or radial styloid, I think, and the scaphoid doesn't look so happy.
She said when she got in there was bad radius scaphoid and radiocapitate arthritis.
Yeah, so I mean that's the issue, and you can actually see that a bit. You can see that there's like a little bit of a osteo or a cyst on the capitate. Actually, that's a good question, Christy. When you get mid-carp arthritis, where does it first start? So like radial carp arthritis starts at the radial styloid, as you can see here. Where does mid-carp arthritis start? Like, where's the first place you're going to see the cyst?
Snack.
Yeah, like in this, or yeah, this or SL.
Radiocapitate.
Yeah, but where?
Oh, like proximally.
So where on the capitate? So the dorsal, the volar, the radial, or the ulnar side?
The volar side.
No, so it's actually the dorsal and
The dorsal
the and this it's inside that it touches the lunate. So it's like right central dorsal. So it's the part that that basically rides on the lunate, and then when the lunate it's like flipped into any aspect of DC, that dorsal like mid part of the capitate is the first place you'll see a cyst. So like on a scope, that's the place where you'll see the cyst form, and when on a X-ray or a CT scan, that's the first place you'll see a cyst, because it's edge loading the dorsal part of the capitate. It's edge loading on that part of the on the lunate, and then eventually getting a ferrous. You can kind of, at least I can convince myself that there's maybe a little cyst on the dorsal aspect of this capitate.
Yeah. Can you
And
see
so
my
in that
arrow?
case, you wouldn't want to do a MFT because you have arthritis, unless you do a styloidectomy with a MFT. And then if you're doing a styloidectomy, then why not just do a styloidectomy and like an AINPI?
Yeah,
But
I would argue the
but I agree with
decision.
Dempsey. I think a four-core infusion is a very reasonable treatment for this.
I think the decision to before what you decide based off of this is you can't really necessarily decide directly off of these X-rays. You probably need to stage it. Sometimes it's very obvious, right? And this person, it may not be as obvious, and you may want something to stage it like a scope, an MRI, CT, etc. Anything that can get you the information that you want to decide what you want to do.
Yeah.
But
Yeah, I mean, I agree with that. I can't say that the person or the surgeon I am now would jump to this immediately.
Spencer, were you about to say, would you do a rib autograft or a hamate, proximal hamate autograft? Is that what you're getting at?
In the absence of arthritis, like I've not seen it, I wouldn't do it. I know there's
So those are reasonable if you don't have an arthritic picture, right? So if you had a proximal pole non-union, I think those are all reasonable options, right? That where the piece is certainly either crumbles or it's fractured, or you're not going to be able to get that piece, right? You can do anything to replace the proximal pole that's going to give you some sort of, hopefully, morphology or back. I think the case series of those are all relatively small, but those are actually probably well within your wheelhouse as well as Christie's, because you guys are used to taking rib for cartilage and all that stuff. So I don't know that it's that challenging, relatively speaking, for y'all, because you're used to working in those areas. Orthopods are not as comfortable typically working around the rib.
I'll talk you into it at some point in the next 6 months.
No. Last time I was around a rib was a chest tube. No.
All right, what's the next case you got? That's
I've got quite a few. So, okay. So this is a 21-year-old male that presented for a right scaphoid fracture. Date of injury was known, the 24th of June. Didn't show up to my clinic for 2 months. Only thing kind of important was he'd had a history of a stress fracture of a tibia. And he played basketball for Life University. He was going to go on to the NBA. So this is the initial films that I had on him. Christy, what do you see?
It looks like he has a scaphoid waist. It's like sort of distal, but it's still scaphoid waist fracture. On the lateral, it looks like his lunate is a little bit extended.
Mm-hmm. And look at the AP of the scaphoid. You see almost like a little cavitary hole there.
Yeah,
you see that little
like
plaque at the radioscaphoid. And in my mind, that's kind of a marker of badness right there. That means that this is not new. Okay, so touch scaphoid flexion, early DC, probably a cavitary bone loss in the middle. So what would you do now? How are you going to work this out?
I would get a CT scan to just quantify how much bone loss I had and the amount of the DZ deformity as well.
Mm-hmm. So I got an MRI.
Okay.
I don't think there's a wrong answer there. Kind of my thought behind this was, and I've changed my thought, by the way, but it's good to talk about anyways. I wanted to see, like, why didn't he heal? How much? I already kind of knew he had bone loss. I knew he was going to need some type of bone graft. He had to be short, right? Like that's how you get a DC deformity. When you have a scaphoid fracture, you get bone loss, the scaphoid shortens, it flexes, the lunate extends. That's also how you know if you've corrected your height for height loss, right? If it's a fresh-ish, still relatively mobile lunate, if you get your scaphoid height back out, then the DC resolves. So that's how you can judge in the OR if you've gotten your height back. But that doesn't work if they've been stuck like that for a year and their capsule's tight.
So Wax, question for you, Dempsey, and everyone else. If you had one option of advanced imaging to get, MRI or CT? And why?
CT.
Interesting. Okay. And how
CT
come?
without question, because it allows me to evaluate mechanical deformity, and there's many studies that show MRI can't evaluate vascularity. So for me, 100% CT.
So you don't think the MRI provides, and I'll be honest, I'm mixed. I don't know if you
I don't think the MRI provides any value.
I think so. The indications, I mean, you saw this, I did this in 2020, just a couple of years ago, but I've changed a lot since then. An MRI for me is if I can't, at this point, is if I can't see the fracture and I think it's a colt, and there's a chance it could be a ligamentous injury.
Sorry, Dempsey, I 100% agree with you. Like, if you're not sure if it's a fracture, MRI is the way to go. And if you think there's any other ligaments, you're 100% agree to go.
Yeah.
I was answering the question about if you know that there's a fracture.
No, I think you guys.
No,
both,
but this was
both answered it well. The short answer is some people always get MRIs, some people always get CTs, some people will tell you for whatever reason that they like, even though that theoretically MRIs have been shown, quote unquote, to not tell or pretend vascular diagnoses as far as whether or not it's dead or not. It's like anytime you see that the thing doesn't light up and is as dark as possibly can be, it certainly makes you think that it's not going to do well. But the data behind it is case series. You're not talking hundreds and thousands. You're talking, was it 20, 30 patients?
So, well, it's also like, why are you getting this, right? Like, are you getting this because they're young and you're trying to decide, do I want to potentially sacrifice the growth plate for a vascularized graft? Or am I getting this MRI to hang the crepe because these people have had this for a long time and like they just don't get it? But the short of it is, if you want to know the bony alignment, if you want to know how much bone loss you have, if you want to know how flexed you are, you need to get a CT scan. I'm tending more and more towards CT scans these days. One, because it doesn't require a pre-cert and delays. It's darn near impossible to get an MRI in a Medicaid patient. There are so many other factors that go into it too.
No, I think what both of you outlined is my rationale as well, which is for those patients that you think you're not sure if they have a fracture or there could be ligamentous stuff, MRI makes a lot of sense. Oftentimes I'll try and get both. I think if I could choose one, a CT for one that that you've definitely got a fracture that you're trying to decide where and how you may fix it, so to speak. So,
yeah,
very valid points. I just say that just because Christy and Spencer, you guys are going to be in a scenario where it's like, hey, you've got the fracture. What am I going to order?
Yeah, exactly. If you guys can think through this now, it will be such an easier first couple of years. So these are the films that I took in the OR. Because he had another like month or two delay getting to the OR for silly reasons. But again, you can kind of see that cavitary area in the body or at the waist, excuse me, and you can see that little fleck. And for him, what I ended up doing was opening it up, curetting all the schmutz out. And then I did end up kind of doing like a capsular swath with some blood supply. This was one of the early Saterianus ones I did.
So interesting. You went.
I know it looks super radial, but
so you went dorsal. No, I'm not worried about the screw plate. So you went dorsal for this as opposed to volar. Interestingly enough.
Yeah, I don't know. I just end up going dorsal a lot. So yeah, but this was, let's see, is this the last one? Yeah, he came back 8 weeks and then he fell off the face of the earth.
Dempsey, when you go dorsal to fix these, what's your move to fix the humpback? Like what?
I mean, you can fix a tiny humpback going dorsally if you just kind of like shove the graft down, but you're not going to fix a big humpback deformity. I mean, this kid was like maybe 10 or 15 degrees tops, and he wasn't as much flexed down as he really was, just a touch short.
Yeah. Yeah, I'll be honest. I don't think the DC in this case would have played into my factor of what I would or would not have done for this specific case. But
yeah, there's a touch. I don't know. He never followed up. I don't know if he healed or not. I certainly didn't like that little lucency there that you can see. Especially 8 weeks post-op, you would hope that you start to see some incorporation at that point. But
I don't want to blow up Wagner's head, but if I were to do this case today, I probably would do it arthroscopically. Wagner, don't say anything. Don't
this is a good one. You're going to see this in your clinic. Okay, so this is a 16-year-old
That's about as good a compliment
kid.
as I can get for gut check.
No, but I will say for the last case, I will say I personally would have gone volar just because it's so distal. And I will tell you that the volar starting point, I do about 50-50 in all honesty. The volar starting point is a little bit harder than you think, only because if you truly have to get center for these patients for like a really distal fracture like that one, you have to go through the trapezium. It's not like you're partially
you've got
that, or you have to nip away at the trapezium to go through.
Yeah.
Now you could do what Wagner and I did on Friday, which is you start dorsal, you push your screw, your K wire from dorsal through to get your perfect center, and then retrograde it back, which is also it's a nice trick, but and then you have to have derotation wires, which is something that you put in, right? You put in a scaphoid capitate pin, a radiolunate pin, and all that stuff. But I mean, you can do it.
Can I ask a question again? When you guys are talking about doing like the arthroscopic scaphoid non-unions, for that, like, do you just pack in like cancellous bone graft? And like, is there like an amount of bone loss that would make you like not want to do, like, I guess like a degree that you would not be comfortable just having cancellous bone graft and want something more structural?
I'll let Wags answer that because he's the one who has done it. I've typically done it the Slade way, which is essentially simple things where there's not a ton of DC. You're essentially packing the graft through the screw hole. The one we did on Friday, we packed through the MCR and essentially the MCR portal. Pardon me. We viewed from MCU, packed it through the MCR, but it wasn't a ton of graft, and they brought it away. But Wags, I don't know. Do you have amount of bone that you would or would not feel comfortable arthroscopically?
No, I mean, I think because we did some unboxing so far down the hill. No, I mean, I think it's the same thing with anything else. What you do is you fill up, you just create like a big bone void until you get back to bleeding bone, just like we did Friday. But like and then you just pack it like really a ton. Some of it you just need a little bit of graft, like on Friday, and some of it you need a bunch of graft. You just pack it real tight with graft. And you put carbon steel on the top of it, and the deal. So no, I mean, I don't necessarily think that so far, no. To answer your question, I don't know the answer to that. I'm sure like the really big humpbacks are at higher risk. But I mean, technically, if you read the data on it right now, which is obviously from very skilled people like BC Hill and Del Pinal, the data suggests right now that they're able to get humpbacks with pretty high healing rates. And so, I mean, I think truthfully told, we'll see. And I've only done a couple of humpbacks that with big bone loss. But yeah, I mean, I actually one of them I took proximal tibia bone graft because I wanted so much bone and just packed it.
The one we did Friday had a I wouldn't say it's a massive humpback, but
it had a decent amount.
It was I mean, that's what I was gonna say. It's definitely there. Like you see the one from Friday, like that's legit. And honestly, that's essentially why you have to pin the radiolunate. You got to pin the stuff so that you can actually get the corrections. You got to pin I don't know. We can always show Friday's case. I don't know if we can.
Yeah, we will. I'm just download the video. I'm gonna send it to Spencer and have him put together and kind of present.
I'll put it together for a complex case at some point.
But Chrissy, to answer your question, I don't know the answer to that, but I so far have not had a limit.
Cool, thanks.
Okay, so next one. This is a 16-year-old high school junior that had wrist pain after a fall playing basketball. He did have a history of a vitamin D deficiency, of course, with no current management. So these are his initial films. Not so terrible. Okay, how about Erica?
Okay.
What do you think?
So when I'm looking at this, it looks, so we're looking at the left hand X-ray, and it looks like I can see kind of a subtle, maybe something subtle, like right in the waist of the scaphoid.
I agree.
And
is he skeletally mature or oops?
No, and he's
everybody close your eyes. Close your eyes. Don't look. Sorry. So skeletally mature or skeletally immature?
Well, so when I was looking at the radius and ulna, I was going to say it's skeletally immature.
Yeah,
so I don't
his
really see much of that going on in the phalanges.
Yeah, those are capped and fused, but the radius and ulna are still open. So he's got a little bit of growing to do, but not a ton. Yeah,
Yeah.
so he's got a scaphoid waist fracture there. Doesn't look like any bone loss, looks non-displaced. So at this point, family didn't want surgery, wanted to avoid it if all possible, you know, the usual. And I said, okay, well, why don't we check a vitamin D level at least? So it was 13. And he was in between primary care doctors and didn't have an endocrinologist. So I said, okay, we'll do 50,000 a week and recheck it in 3 months. So this is 8 weeks into conservative care. What do you see now?
So I still see like lucency in the scaphoid. It does look like
Does
the
it look
radius.
better, same, or worse?
I'd have to look at it next to the old one.
Let's look at that oblique.
Okay.
And now look at this one.
It almost looks worse.
Yeah, I agree.
Okay.
I agree. This is what happens when you have low vitamin D.
Dang.
Or that's what I blame it on, at least.
Okay.
Yeah. So he's 8 weeks into the fracture. It doesn't look like he's healing.
Wait, so Dan, can we stop there for a second before we go on?
Mhm.
Just poll the, as I like to say, poll the audience.
Yeah.
What is your method of immobilization for patients with a scaphoid fracture that you're going to treat non-surgically, I should state?
So I do a thumb spica exos locked. I don't teach them how to unlock it until later on. So
Gotcha.
basically a thumb spica cast.
And then how often, I mean, I say this, and then how often do you bring them back for x-rays? Is this someone like, you know, like typically, right, just the way is you bring them back every week and you get x-rays for 3 weeks? Do you say, hey, come see me in 6 weeks or 8 weeks? Well, I guess
Yes.
what I'm trying to say is for Spencer and Christy who rotate off, right, every month or whatever, they don't really actually get to see follow-up. So take me through, you see someone, you diagnose them that they're non-op, you go straight to putting them in an exos, long arm, it sounds like, locked in a thumb spica, can't take it off, plastic bag for showering, that type of
Yes.
stuff.
Especially for teenagers. Especially for teenagers.
And then you see them back at what time point? 6 weeks? 8 weeks?
Usually, if we're gonna, like, the first visit is time 0, I'll see him at 2 weeks and I'll see him at 6 weeks. So that'll get him to 8 weeks. And if I don't see healing by then, I've got to change what I'm doing.
Gotcha. So you see him at 2 weeks, then technically at 6 weeks, which would, or at 8 weeks technically, which would be 6 weeks status post that. And then if you're concerned, you may get a CT scan plus or minus and then switch if you need to. Now, let's say you think that you see healing. Do you let them come out? Or what if you're, I mean, what if you're concerned? I guess these are the different things I'm asking before we go, just since I'm assuming every other case we're going to go over is surgical treatment.
I mean, if I thought I saw it was healing and it was somebody that was responsible, or if it was like you, I would let you take it off to shower. But most teenagers, if you say you can take it off to shower, that means I can take it off to go to school. So teenagers, how much I let them remove it is directly proportional to how much I trust them.
Okay. Wags, anything different from what Dem said that you would do or not do? Or Wags, Zelensky? I don't know who else is on. Sorry, Nikki, I can't see that you're. Yeah, Wags or Zelensky.
Dempsey, how did you say you immobilize them?
Thumb spica exos. He said long arm, but it's a short arm.
It's the black thing that the sports guys use. I hate it personally, but that's only because they never lock it and they take it on and off and they let people shower. So when they come back, they've got Pseudomonas underneath it. But yeah.
Like never have I ever.
Oh yeah, we've seen the swimmers. They put all the swimmers in it, and I'm like, yeah, this is not waterproof. Just
no, that's why we have custom orthoplast.
Anyway,
never have I ever. Okay.
I haven't played that game in a long time. So Nikki, or Wag. So what do you guys do for your stuff?
So I just attached an article that kind of helps, or so I don't do thumb spica because the article I just attached. There's like this kind of cool scaphoid biomechanics project that looked at scaphoid motion and looked at the forearm motion and thumb motion and looked at what's critical to keeping the scaphoid stable. And really the only 2 motions that are critical to keeping the scaphoid stable are wrist extension and ulnar deviation. So that I don't do thumb spikers or long arm cast because of that study that I just attached to the chat. So I just do I have our therapist make a kind of a volar and dorsal wrist immobilizer. So almost like a radial gutter.
Radio cutter. Like a clamshell?
Kind of like it, not, but it doesn't go all the way up the forearm. I call it the scaphoid. The ones in EP know it is the scaphoid screw. But it's kind of like a radial gutter. It's like a. Oh,
I said, now I'm really curious.
Yeah, so it's like has this, it has this, and it has like kind of like a kind of connection between here and around this side. So it's kind of like a radio, like you would fashion a radio gutter. But if you tell the people downstairs you want the scaphoid split, they know it, or they seem to know what we're talking about. I think it's the same way in the Gulliver used to do it.
It's interesting. A lot of people have switched to short arm casts. I don't know. I still put them in thumb spica, even though there's technically not just that article. There's actually one or two other ones, one out of Europe as well, that showed that there is no difference in treating scaphoid waste with it. I always just say, look, the problem is I feel like you give them an inch, they take a mile as far as patients are concerned. But I was just curious because it is controversial. Interestingly enough, actually, it was not that paper, but the European paper that my co-fellow and I actually did a study, and we used thumb spica versus non-thumb spica in healthy volunteers and asked them to do daily activities. And a thumb spica substantially hinders your ADLs. Just FYI.
Yeah, that's why I put them in a thumb spica.
That's why I like it. They're like,
That's
I
why I
can't
do
do
it.
anything.
You gotta shut them down
What
otherwise.
a coincidence. What a coincidence. You can't do anything.
Yeah.
So anyway,
for that initial x-ray, like, would you have gotten a CT scan to confirm that it was non-displaced? Just because I was reading in Greens and it was like, if you can see the fracture on the x-ray, then like it's considered unstable. So like, would you get that before you like talk to the patient?
not in a
about, like,
kid. He's 17.
So, but that is a great question, right? So this goes back to, as I was saying, you cannot get people to agree on whether something is displaced or non-displaced, right? So like, as you said, some people say like, oh, if you can see the fracture gap on an x-ray, it's displaced, or et cetera, which it's like, that doesn't technically look displaced. There's probably lucency, but that's probably because of lysis after 6 weeks or whatever, or 8 weeks of being treated. So it's very interesting, right? I would not consider that one displaced. I would just consider it a delayed union at this point, right?
Yeah. And I figured you heal a little bit slow with a vitamin D of 13. So anyways, so what do we do now? 8 weeks out, you got a bigger hole. I kept talking to the family about the surgery. They really, really didn't want surgery. So I said, okay, fine, let's get a CT scan. His insurance did require a pre-cert. So the CT scan was actually done about 10 weeks into his injury. And you can see here, this is not healed. It's not healing. There's no remodeling. So that brings up another good point. If you're trying to non-op somebody and you get a CT scan, like at what point should you see bony healing? And that if you don't see it around the 6 to 8 week mark, they're not likely to heal going down the conservative path. So
yeah, you can see it as early as 4 weeks, believe it or not.
Yeah.
In scaphoid waste, that is.
What do you do with this kid now? Spencer, what would you do?
He needs surgery. Was he gonna agree to it finally?
Yeah, they finally did. Not before they cost him a bunch of bone grafting, but yeah, they finally did.
I would just graft, and I'd probably do just cancellous and then a screw. And this one, you could probably do dorsal because it's more of a mid-waist distal, and that shouldn't be awful.
Yeah, that's what I did. I tried to stay out of the physis. I found the physis. I mean, it's about shut down anyways. But just to be, proper, I found the physis on the x-ray and then just took bone graft from it proximally.
So let me ask you this question. When you go dorsally and you put in graft for these patients, are you taking down the dorsal ridge, or you're trying not to take down the dorsal ridge?
Try not to. I think some of it's invariable, but
And
3
someone
months
like
post.
him with the vitamin D deficiency, would you like try something like the phone simulator or whatever?
I mean, you can try, but I didn't bother with him because I knew his insurance wouldn't cover it.
Okay.
But yeah, I mean, there's no harm. There's no harm. So you can try whatever you want. So that's 3 months. Looks like he's slowly starting to eke along. Had some compliance issues. He kind of fell off the face of the earth for a while. And then he decided to come back when he wanted to play football again. So that's why there's a giant gap from like 3 months to 10 months. So at this point, he came back and he didn't have any pain. But he wanted to play football. And even if it's 10 months out, how would you, I mean, Spencer, would you get any other imaging here, or Christy?
I would CT him. Like I would have CT'd him months ago, but since he just came back today.
Yeah, look at that funny little area at the proximal pole of the scaphoid.
Yeah, it looks like
Yeah.
lumpy. I don't know why, but
Yeah. Anyways, so yeah, that's what I did. I got a CT scan. Showed he had about 60 to 80% healing. I cleared him to play, and then 2 weeks later he tore his ACL.
that's what you get.
No, I always tell them they can do leg days. Clearly did not do leg days. Some people, they're just not meant to be athletes. Just not. Man. So anyways.
So that actually is one other thing is how much on a CT scan do you need to actually allow them to return to play with the screw? There's a study actually that looked at it.
Oh, I gotta check. You're the lead athlete expert. When do you
Well, that's what I'm saying. So if you have a screw in place and there's 50% approximately of the area that demonstrates healing, they can return to play.
That's the Sing one, right?
Yeah, it's from Sapienza from NYU, and they did it biomechanics.
So yeah, didn't do any leg days. Tore his ACL 2 weeks after I cleared him.
These people are prone to injury, as I tell everybody. People that play sports get one injury,
yes.
Oftentimes in those, like they get re-injured and re-injured and re-injured.
I agree. I totally agree. That's a sign that you should like use your brain, not your body. I was obviously not an athlete. Anyways, moving along. We've got another one. This is the last one. It's a good one. We're almost done because we're over. Okay, 27-year-old male presents to my clinic 3 days after a fall from a 12-foot ladder. These are his x-rays. Okay, Christy, what do you see there?
Displaced scaphoid waist fracture with like a little extra fragment out radially.
Mm-hmm. Look a little funny to you? Would it make you ask? That's just like a super clean fracture line.
Is it old?
Yeah. Always ask. I swear this little fleck right here, that little fleck on the radial side, that's like the marker of badness. Every time I see a little fleck over there, I feel like it doesn't go well. So that means he did great. So I asked the kid, or the gentleman, excuse me, multiple times. He's sure you've never fallen before, no high school sports, no nothing. Swears up and down, never injured it before. Okay, fine, we'll just fix it. So I get into the OR and I was like, I'll just pin it volarly. We'll just go volar this time. I haven't done that enough lately. I'll just do it volar. And then I start to get the pin in and the fracture just starts moving all around. There's just no stability and it just wasn't handling right. And I didn't like how it moved. And the bone just felt really soft and I just didn't like it. And so this would have been one where it should have, if I had the foresight, I would have scoped it first. Because I then abandoned the volar, went dorsal, opened it up. And you could see like there was no blood in the joint. There was no bloody staining of the cartilage. Usually if it's an acute scaphoid fracture, you'll see some of that. He didn't really have any. And then when you got to the fracture site, it was just kind of full of, like snot. So what I think happened with him but he's not, if you look at the lateral, he's not in DC. He doesn't have any flexion of the scaphoid, any of that. But anyways, by the end of the case, it was pretty apparent that it was actually not a new fracture. My best guess is he had, an injury when he was younger, and he had like a fibrous non-union, but it was kind of stable, and then he fell and he ripped the fibrous non-union and then had pain and then got an x-ray. So I ended up bone grafting him from dorsal, but I didn't do a vascularized graft because the bone looked healthy, looked like it was going to heal, and you could see bleeding when I dropped the tourniquet. Not that any of that matters, but that's what I did. So here's 3 months post-op. Still got a fracture line. What would you do, Christy? And he's still hurting.
Get a CT scan, just like quantify if there's any bone healing.
Yeah. And that's what I did. And you can see that the fracture line is still there. There's no healing. The bone graft is kind of sitting there versus maybe starting to melt away. And a little bit of sclerosis on the proximal pole. So maybe it's not healing. Maybe it's dying. So what do we do now?
Ostrich.
Do what?
The ostrich.
Oh, stick your head in the sand?
That's right.
I was gonna say,
Now we got fellas to teach.
But bone skin.
I already did that. I've got him on vitamin D, bone stimulator.
I mean, the other option at this point, right, is one option is immobilize them for longer. Not that everyone likes that. The other option is go to vascularized bone graft or those kind of. I mean, those are right. You can go up the ladder. It's harder because you lose some of the screw purchase, and then you got to decide how you're going to get fixation. Are you going to use K wires, all that stuff.
Right. So with this one, well, on December 19th, we're going to do a vascularized graft volar.
This is I got you. You got another one. All right.
Yeah.
What are you gonna use for fixation, or are you gonna use your screw?
Honestly, I'm gonna try and leave the screw in.
Back it out and then put it back in.
I was gonna open it up volarly and just look at the fracture line and burr it out. Get all the stuff out. If I still have fixation, keep it. If I don't, you can just always add in another screw from the volar. Like did a scaphoid last week where I put a 2-0 screw in. I didn't really feel like it had enough fixation, so I then added, Synthes has like a 1.5 screw.
Oh yeah,
I actually really like that. Yeah, you can sneak it around. So my plan was to try, because this is on the CT scan, I couldn't get the images on there because I don't know, the PAX wasn't uploading the images for some reason. But anyways, it's not like it's collapsed yet. I think the fixation is still okay. I was just going to try and burr it out and see if we could add in the volar graft. Because like we're really doing the volar graft for the blood supply. I don't think I need a lot more bone. I just need blood supply.
I mean, look, you might be able to leave the screw in and actually wedge it in, right? If you take out like a rectangular wedge or something like that and do it.
Yeah.
I don't know. It's always challenging. One thing I personally have not done, granted, they did it when I was a fellow. They actually did the first one, I think, in the country. Was they put in the little plate on the volar aspect of the scaphoid. That was actually at Bellevue, and they did it for like a ballistic injury, which the discussion at conference that I think the following week after they showed the plates on the volar part of the scaphoid was interesting. But
well, it was already toast, so we figured we'd put a plate on it.
yeah, but I mean, look, the plate's actually a viable. In all honesty, you may want to consider having the little Med Artist plate as a backup. God forbid something goes horribly awry. Never hurts. I've never used it, but K wires also still work well, as I tell everybody.
Yeah.
I hate the scaphoids, by the way. And I didn't mean. I apologize for interrupting you earlier for the delay in diagnosis, but I feel like that's always like people come in and they're like,
No,
I thought I sprained it. And
yeah, that's really important. I don't take that personally at all. That's really important.
But I would have interrupted Wags way more if it makes you feel any better.
Can you go to the X-ray?
Just go look back at the recordings and you can see how often he interrupts me when I try to talk.
I let you speak your entire sentence 2 seconds ago.
Go back to what, Spencer?
Take it back to the X-ray.
That one?
Yeah. Would you scope this to try and clean out the non-union? Like, I know you're gonna open it for the graft anyway. Like, but you get all the shit out around the screw and then like fit your.
I don't know. Would you do that? Right here, would you do that?
How much time do you have? Do you have like 6 hours?
Yeah, Dempsey, when you doing this? Do you want to do it?
December 19th.
I
Yeah.
only
December
say
Like with the
19th.
end of the day.
because if you still have fixation, like if that screw's good and you could not take it out and
Yeah, Dempsey, let's do it at the end of the day on December 19th.
the
Let's scope
burr,
it and see what we can get up.
it might be a hot mess, in which case you're gonna open it anyway and you just abandon it. But the burr
Yeah,
was
but we'll
really
dry scope it so it won't burn any bridges.
the burr was really, and you're not gonna devascularize it anyway, but I don't know.
Just remember, this has already been opened. Both
Yeah.
sides, correct?
Yeah.
That's fine.
I abandoned the volar pretty quickly. There was a percutaneous.
It's more so just for the mechanical parts, like the burr fits in there nice without like, I feel like a curette is hard to, I don't know. The burr was nice.
Dempsey,
but-
let's scope it. Let's scope it, drive it out, and see what we think, and then you can always open it if you decide you don't want to futz it too much more.
Yeah,
But
you
add it
open
on the end of the day on December 19th.
I mean, he's getting a vascularized graft. I think
Yeah.
he has to get a vascularized graft. So the point would be to scope
Are you
it.
taking out the screw?
I don't want to.
it-
It's only been in there.
How are you
3
going to fit a
months.
vascularized graft in there if you're not taking out the screw?
My hope is that I can just burr it out and press fit it in and maybe hold it with one of the little Synthes screws. One of their little 1.5 headless screws.
Huh.
Yeah, we're gonna see how that works.
But like the burr was actually just very nice to clean out the non-union site. I'm not talking you into anything. So, but if things go bad, you can still blame me.
Sir, unicorns, rainbows, and sunshine. Eternal fount of
One thing,
optimism.
I realize we're over, but one thing I will
Yeah,
tell
we're
you.
way over.
One thing I will tell you is that if I could convince everyone to take iliac crest bone graft, I would almost definitely do that for all my scaphoids. The problem is most people don't want it. It's painful, but I do think the graft from iliac crest bone is so much denser and better than what you get from the tibia or the radius, but it's not a benign, it's by no means a benign graft source. But it is the gold standard, but it's definitely not benign. Ironically, I still think the distal radius is nice and easy and convenient and works reasonably well, but I just say that just so you guys are aware. I don't really necessarily need structural graft for the vast majority of scaphoids. Like for instance, this doesn't need technically any structural graft, right? Theoretically.
Yeah. No, I think he just needs blood supply. I think he just had a non-union hanging out forever, and he just doesn't really have any vessels in the middle to bridge it.
One thing we didn't talk about, I realize there's so many different controversial things, is how much compression you get with which device, and if you think that any of the screw designs matter.
Oh gosh. Yep.
I say that some people will tell you a Herbert screw through and through. Some people think that the AccuTrax, which are these work just fine. There is a subtlety, I will tell you, to some of these headless compression screws, which is you got to make sure that the screwdriver is the same diameter as the distal end of your screw. And what I mean by that is, like, if you come through the trapezium, like what we did, Spencer, on Friday, and the back end of your screw and the diameter of your screwdriver are different sizes, like, there's a small portion of the screwdriver and then the diameter is different, you can't get the screw all the way down. And that happened in fellowship, by the way. And you're like, what do we do now? And it's like, you have to drill a larger hole through the trapezium, essentially. That's what you do. You take a cannulated drill a larger hole, and then pass it through.
Probably sucks taking that screw out to do that though.
But you understand what I'm saying, right?
Yep.
So, I don't know that one. There's a study I actually wanted to do with like Fujifilm and the different stuff and see if there was a compressive force that was better with one type of screw versus the other, but I don't know that they truly matter. I don't know. I will tell you that occasionally what I find is that if you do not drill completely through the other cortex, that if you put the screw in, you can actually gap the fracture.
That Fujifilm thing wouldn't be hard.
I'm always still interested in it.
Yeah,
Willing,
like we just need money for screws, but the cataract bone we'll have from Steph.
the problem was the moisture of the cadaveric bone to do the Fujifilm.
What do you mean?
The cadaver bone was too moist.
You can just. Does it have to be moist? Can it be?
No, you don't want it to be. I'm just saying, normally cadaver bones are defrosted, right? You thaw them and then you use them. Anyway, we can
We'll
discuss
talk
that
about it
another
later.
day.
Not
But
at
I think it would be interesting to look at variable, which if there's any screws that have a better true compressive bite. Anyway, great, interesting discussion. There's obviously a lot of controversy around these. I still hate them.
We managed to talk for an hour and a half.
So
Sorry, guys.
no, it was good. It's great talk.
Dempsey, great job. This was
Thanks,
very stimulating, very fun.
Thank you.
Very interesting.